Hello, everyone. This is Dr. Tony Scuderi. I hope you're doing well. This is week one of counseling psychology in InterCoast College. I'm a professor for this course. I'd like to give you a couple video presentations very quickly, just to give you some pointers on what you're looking for, and I'm going to base this on your final paper. So let me share a screen with you. Let me show you exactly where we are. And let's go to slideshow and begin this. Okay, so as I said, this is counseling psych. So let's talk a little bit about beliefs, values, and changes, because part of what you're going to have to do is come up with your own theoretical basis. So I'd like to talk briefly about starting your own system of therapy. And yes, it's not impossible to do that. Everyone should have their own system of therapy. So let's look at your style. Being true to yourself, your boundaries, transference, countertransference, your theoretical basis for practice, development of you as a counselor, diagnostics, how to talk to docs, and then we'll close up with impacting the client, meeting the client where they are, and follow-up. So starting your own system of theory. The way to do this is, first of all, you're going to have to do reading. You're going to have to understand what's going on. You've got your assignments in class that are going to help you. We have YouTube. We have all kinds of things out there for us to look at. So what I need you to do in starting your own theory is to look at different ways that clinicians do their thing. Look at, for example, the humanistic approach, Carl Rogers. We'll talk about that in another week. But not just Rogers. You want to look at things like Eric Beck, cognitive behavioral therapy, maybe Marshall Linehan, dialectical behavioral therapy, B.F. Skinner, behavioral therapy, Sigmund Freud, even psychoanalytic theory, all these different theories. Look at them, read them, understand them, and find out which one speaks to you. Once you find out which one speaks to you, that's where you want to go. There's no such thing out there as eclectic therapy. Eclectic therapy, if I ever hear somebody say that, that basically tells me they have no idea what they're talking about. Eclectic therapy is basically a little bit of this and a little bit of that. Let's see what works, throw it at the wall and see what sticks. That does not work in a clinic. That does not help your patient. What helps your patient is a good, sound, theoretical basis that you will have. So the first thing to do that is to look at your style. Who are you as a person? Get to know yourself. Understand yourself. Be true to yourself, because when you walk into the clinic, that's what's in front of the patient, not some whatever. You are in front of the patient. You have to be yourself, right? I mean, I've been a super clinical supervisor for forever. And when I observe my supervisees, sometimes I see them sitting there very stoic and very, how are you today, sir? And could you tell me what brings you here today? How are you? What's this? What's that? Why do you feel this way? Why do you feel that way? And it's like the Spanish Inquisition. It's terrible, right? Talk to your patient. Understand your patient. It's a conversation, okay? If they're doing drugs and alcohol, look at it not as you're an addict and an alcoholic, but look at it as a symptom to the problem. They're medicating a problem using the substance. For those of you that may have had your own addiction, you know what I'm talking about, right? So there are issues that you had that made you turn to that drug, turn to that alcohol. So you've got to address that. Address it as a human person, just like I'm talking to you right now. Be true to yourself. It doesn't mean reveal yourself. I'm going to talk about that in a second with boundaries. It doesn't mean reveal yourself, right? Everything about you, because now the session switches over to you instead of them. Being yourself is, who are you? What kind of a person are you? What's your style? What's your swag, as we used to say back in the day? The other thing you want to take a look at when you're developing your own style is understand your boundaries. There are two terms, transference and countertransference. Understand what they mean. You'll find this in the literature, and I'll explain it right now. Transference is the patient's feelings, emotions, and from the past placed on to you, because you to them signify something. You're a metaphor for someone in the past. Maybe their mom, maybe their dad, maybe a drug dealer, whatever it is, a friend, a brother, a sister. So they're going to talk to you and they're going to think that you're that person on an unconscious level. So their feelings and their emotions are going to be placed on you. This is why you have to have a very hard skin, because sometimes what happens with this, when they start to do the transference, excuse me, when they start to do the transference, it can get brutal. Countertransference is you, the therapist's response to that based on your own baggage. So if I were a client and I were to sit there and I were to say to you, I wish you wouldn't talk to me that way because you sound like my father. What you don't want to do is sit there and say, well, who do you think you are? You want to approach that. I understand. Could you tell me what part about me reminds you of your father? And let them talk. Oh, so whenever somebody approaches you this way, it's like your father is talking to you. And if they, answer in the affirmative, yeah, you're right. Okay, do you understand I'm not your father? So let's talk about the way that people talk to you in this vein and how you can respond to them differently and be okay with it. Okay, that's how you work the transference, countertransference. So much more complicated than that. But when you do this, the thing is to start to develop for yourself a theoretical basis for practice. So your style may be one of being open, friendly, honest. That's Rogerian. That's very client-centered, right? So you want to meet the client where they are. So when you're doing that, you talk to them that way, but then all of a sudden you find out that doesn't work too well after a while. So now what you have to do is you've got to go and you have to listen to what the person's saying and say, well, your thought process is very challenging. It seems like that what you're doing is you're talking yourself into getting sick, and this is how you're doing that. Well, now you're going to cognitive behavioral, right? So now you sit there and you go, well, I need you to do this for homework. Or maybe as the person's talking, they're sitting there like this, and so how are you feeling right now? I'm feeling just fine. Well, now all of a sudden you point that out. Well, if you're feeling fine, how come your voice is very rough and your arms are crossed like this? What's that about? I want you to really tighten up your arms and really tighten up your face like you're angry and get a feel of what that's like, because I'm not sure you really know that that's what's happening. Well, now you've just moved into another theoretical basis. Okay. That's called Gestalt therapy. So to find your own, you have to understand these different modes of psychotherapy that have been used in the clinic, and then find what works for you, blend them together, and come up with your own basis, your own theoretical basis. That's not eclecticism, all right? Because I'm not addressing this as sitting there saying, oh, well, this isn't working, so I'm going to go here, I'm going to go there. I'm taking what I've learned and I'm pulling it together. So that's part of your theoretical basis. Where do you get that from? You get that from your clients. So when you have your clients, talk to your clients as you would want to be talked to yourself. One of the things that made me a very successful clinician and supervisor is when I would talk to my clients, my patients, my staff as a human person, the way I want to be talked to. I'm not going to bark at them. I'm not going to yell out orders. I'm not going to tell them you got to do this or else. No, that's garbage. What you want to do is you want to talk to your patients, talk to your clients. Okay. When you do that, they're going to be very responsive to you, and they're going to do a technique called joining. Joining is when they can relate to you and say anything to you and understand it. The next thing about your theoretical background, your theoretical basis, is understand diagnostics. The Diagnostic and Statistical Manual of Mental Disorders, 5th edition revised, is the current DSM-5-TR. That's the manual that clinicians use to diagnose their patients. You need to look at that. You need to understand that. You need to be able to finger through it and understand exactly what you're looking at with your patient. You're not going to be diagnosing, but you've got to know the diagnosis. What do I mean by that? You can't treat what you don't know. So if you understand what you're looking at diagnostically, you can sit there and you can see the signs, the symptoms, the criteria, and that way, you know what you're looking at, so you know how to approach and talk to your patient. If you don't do that, if you don't understand that, you're not going to understand what you're talking to or what you're doing. Also, what this does by understanding diagnostics, every clinic has to follow a medical model, at least here in California. So if you follow a medical model, you're going to be talking to a psychiatrist because your medical director is going to be a psychiatrist or a physician. You got to know how to talk to a doc. If you don't know how to talk to a doc, you're not going to have a job very long because docs can get very, very picky. You don't know what you're talking about, right? Now, that doesn't mean that you have to be a doc. It means that you have to understand the lingo, the language. You're going to get that through the diagnostics. So read psychopathology, understand your materials here. Why? Because it impacts your client. That's why. It impacts your client. And to do that, you want to meet your client where they are. Don't try to make your client anything other than they are. If they're still using, they're still using. You're not going to sit there and tell your client, stop using right now. That's just impossible. Meet them where they are. Find out what the symptom is. Find out what leads them into it. Find out how they get led into it. How they feel about themselves before they use. How they feel themselves during use, after use. What they have done in the past not to use. What stopped them from staying on that track? What made them relapse? Get to know your client. Meet them where they are. Never tell a client what they need. The client will tell you what they need. Read motivational interviewing. That will give you a good basis as to how to approach a client, how to talk to a client. Most importantly, follow up with the client. Make sure you know exactly what the client is saying, how they're saying it. Call them a week after, a couple days after. If they're suicidal or homicidal, put them in a hospital right away. Talk to your clinical director. Whatever it is, follow up with your patient. That shows that you care. The patient will come back. You don't follow up, they may not come back. They may not come back. There may be some issues there. All right. So the belief, the values, and the change. I want to stop here right now and give you a chance to just take a look at this, listen to this, and continue on your first week's work. If you have any questions, please feel free to give me a call at 916-767-7876 or drop me an email at anthony.scuderi@intercoast.edu. All that information is on your dashboard under Meet Your Professor or Meet Your Teacher. And I hope to see you in the following week. Reach out to me as I reach out to you. Take care and thanks a lot.